Hello doctors, welcome to Chennai Women's Clinic and Scan Center's Dialogue series. This is a part of our initiative to leverage technology to best serve the medical community through healthy debate and discussion. I am Dr.Deepthi Jammi, Consultant Fetal Medicine Specialist at Chennai Women's Clinic and Scan Center. Today, we have a couple of young, eminent gynecologists practicing in Chennai. We have with us Dr. Nithya Ramachandran, who is a postgraduate from Government Medical College, Kottayam, who is currently practicing at SIMS, Motherhood and Cloud9 hospitals. Her special interest would include endoscopic surgeries. We have Dr. Anusha Raj, who is a postgraduate from Institute of Obstetrics and Gynecology, a part of Madras Medical College, Chennai, and is currently practicing at SIMS, Medway Hospitals and Cloud9, Chennai. Her special interest would include high-risk pregnancy and endoscopic surgeries. We have Dr. Kritika Kaushik, who is a postgraduate from Bangalore Medical College and Southern Railway Headquarters, who is currently practicing at Jain Group of Hospitals and Cloud9, Chennai. Her special interest would include high-risk obstetrics as well. So today we are going to actually have a healthy debate among all of us. So we are going to talk about a most common condition where we sit in our OP as gynecologists. The most common condition we come across is a case of primary infertility or subfertility. So the literature says that in spite of all the investigations being done, there are a subset group of patients, almost 10 to 15% of them are having unexplained infertility. So it's a common scenario, as I said. So let's talk about the first line of management with ovulation induction drugs. So as I said, it's going to be a healthy debate. Let's involve Dr. Nithya first. So I'm going to throw up a case for you now, throw it up to you. So how do you think, or what would be the ideal management when you come across a patient, say a couple who is visiting you for the first time? They are married since 2 years and they're trying to conceive for the past 1 year, but it has been unsuccessful. Having said all this, you have counseled them about the fertile period, you have actually taken the baseline blood investigations, the husband semen analysis, and in ultrasound it showed up that the patient was a bilateral polycystic ovaries syndrome. So that was your ultrasound picture. But other than that, there wasn't any much information on the blood parameters. So Dr. Nithya, how would you want to proceed with such patients? And since all the other parameters are normal, what would be your first line of ovulation induction drug? You are planning on a follicular study. Okay. So how will you go about this patient?
Deepthi, let me just give you the prevalence of polycystic ovaries in India. Among adolescents, it is about 9.6%, and in reproductive age group, it's from 2.2 to 22%, and it is obviously on the rise. Yeah. So PCOS becomes a separate topic of discussion. So I would like to go with the medical management in this case, because everything else, you have made my job simpler by telling that everything else is normal. Yeah. So the dosage of Clomiphene citrate, I would like to begin it from 50 milligram, then rise it to 100 and then 150. Okay. Though the books tell that the maximum dose is 250 milligram, generally we don't go up to that dose. We stop it at 150. And the mechanism of action of Clomiphene, it acts on the estrogen receptors on the HPO axis. Okay. So the endogenous estrogen level is perceived as low. Okay. So thereby there is a change in the pulsatility of GnRH. So there is increase in FSH and LH levels, thereby recruiting multiple follicles. Okay.
So Dr. Anusha, would you agree with Dr. Nithya, or because I told first it's a debate, so you have to justify your point. So are you going to start on another drug for this patient, same patient when she comes to you?
As Dr. Nithya rightly pointed out, CC would be ideal for this patient, but I would like to consider the start of Letros for this patient because I would like to stress upon the goals of ovulation induction, which is something should be cost effective. Okay. Yes, of course, CC is cost effective and ease of administration. And you need to achieve monofollicular development. And you need to minimize the risk of OHSs. Okay. And also, you need to aim at a singleton pregnancy. Okay. So, keeping all this in mind, and you need to comply to all this. Okay. I would like to start the patient on Letros.
Okay. So, Nithya, so she's made your job a little difficult. Now, what you have to do is you have to convince me, why would you want to start the patient on Clomiphene, not Letros? So, now you tell me, what are the pros and cons of a Clomiphene as a baseline drug?
See, Deepthi, it is a well-studied drug. That is what is my first point. And though the ovulation rates for both the drugs, Letros and Clomiphene, is almost the same, we need a larger randomized control trials to prove which is better. So rather than having fight among Dr. Nitya and Dr. Anusha, there should be a large group of trial which is yet to be conducted. I do agree, as Anusha said, that the incidence of OHSs is higher in Clomiphene because of recruitment of multiple follicles. And it's got its own anti-estrogenic effects. So Deepthi, let us bring you in. What will you tell us on the endometrial findings in a case of Clomiphene citrate, or when we send the patient for a follicular study?
Okay, because apart from obstetric scans, we get a lot of referrals for ultrasound in infertility. There are referrals which says do a particular Doppler in ultrasound when you're dealing with a follicular study. Let it be a routine follicular study, a natural for a natural conception trying, or for an IUI cycle, or even for an ART IVF pregnancies. So the recent developments in Doppler and infertility are actually taking a huge role. So there are a couple of things where we use Doppler in cases of ultrasound infertility. Two things I want to make a point here. One is Doppler in endometrial vascularity. So we all know that when we look at the endometrium, like a routine gynecologist will do a follicle by herself. So, but when we involve Doppler into it, we want to see if the endometrium, first the pattern, that's a triple line, you have a hypoechoic structure in between. They say that if the endometrium is between 8 mm to 12 mm, irrespective of whatever you are, it's trying either a natural or an IUI or an IVF, your success rate is good. So, an ET between 8 mm to 12 mm, if it's a triple layer pattern, that's very important. The second pattern, important point for coming to endometrial vascularity is, there are actually 4 zones. So the endometrial vascularity zone, when we divide, as I said, there are 3 echogenic lines, hyperechoic lines in the endometrium, which is submerged, sandwiched between 2 hypoechoic lines. These are because of the mucinous glands in the cavity. So the zone 1 will include the endomyometrial junction. So if your vascularity is only up till that endomyometrial junction, and zone 2, which includes a little beneath the hyperechoic zone. So zone 1 and zone 2 vascularities are not that good. If a patient is showing only vascularity up till zone 1 to zone 2, that means the cycle might not be as effective. Not that she will not get pregnant, but then when you compare to the vascularity which extends till the zone 3, that is the middle, almost between the other 2 hypoechoic and the hyperechoic lines, and the zone 4 actually touching the echogenic line, which is right in the center. The zone 3 and the zone 4 Doppler vascularity patients conceive in the cycles when we are tracking follicular study. And also the uterine artery Doppler. The research also says uterine artery Doppler, when the PI is less than 3.2, with a zone 3, zone 4 vascularity, along with the endometrial pattern being triple layer and 8 mm to 12 mm, those pregnancies are the best, and you can also get a lot of success rate in those pregnancies. So OHSs, I'm pretty sure we know, like how you said, ovarian hyperstimulation syndrome in ultrasound, we do suspect when there is more multiple stimulated follicles of varying sizes, not just one size, multiple follicles, varying size, when the ovarian size is more than 12 centimeter. And when you come across an OHSs, it's essential for me to let you know whether there is a ascites or a pleural effusion, because that would differentiate, and that will actually I think that will be the mainstay for your treatment as well. So apart from all this, having said this about Clomiphene, so Dr. Anusha, would you want to elaborate on the Letrose? Because we know that Letrose is on and off the market for quite some time. We see some Letrose is there in the market, then it's withdrawn, then now again it's come back. So would you want to elaborate further on the Letrose?
Sure. See, when we are talking about OHSs, we are talking about multiple follicles. Now, what we are aiming is monofollicular development. What Letrose does it? Initially, Letrose also acts at the hypothalamic level. When you give Letrose between day 3 to day 7, when it is on day 5, you have the maximum suppression of E2 at the ovarian level. What happens is, this again causes a negative feedback mechanism, rise in FSH, and multiple follicles are recruited. But what happens in day 10? We know very well that it is a short-acting drug. On day 10, when the levels of the drug goes down, what happens? Again, a physiological negative feedback occurs. The level of E2 comes down, and a physiologic goes up, and a physiological rise in FSH occurs. So what happens is, again, estrogen is increased inside the follicle, and only a dominant follicle grows, and then you have atresia of the other follicles. That's when I think Dr. Deepthi, you can tell. You would have seen a lot of cases where patients have been induced with letrose. You can see a single follicle, good follicle when you see the patients in day 10. Which you don't see in CC or CC with gonadotropins.
Yeah, that's right. You are trying to pull me towards you now. So I will actually have to ask, then why was it, so you've told me beautiful things about letrose, then why was it withdrawn from the market?
It was withdrawn from the market because of few sporadic cases of congenital anomalies of the heart and of sacrum also. But then now there are perfectly done animal studies which says there are no congenital anomalies, but then there are more studies to be done. I mean, doing a study in humans is not that easy, but then there are more studies, and letrose is definitely having a great comeback now.
Okay, so she has actually made her point very clear. So I am being neutral still, so I am giving you a fair chance, Nithya. So how would you, do you think Clomiphene, that is Clomiphene citrate alone is good enough for your polycystic patients, or would you want to add any other injectables to it?
See, as we become better with the team, even with Clomiphene, that is the case. Okay. So, when do we tell a drug is resistant? Like, for example, Clomiphene, only after 3 cycles, when we don't find ovulation happening, then we would call it resistant. So, definitely in obese women with PCOS, metformin plays a role. So, we have studies which tell that metformin improves the ovulation rate. And so the other drug which I would like to add is gonadotropins. So, and I think Dr. Kritika is here to tell us more on gonadotropins.
Thanks, Neetu. So Neeta has the clone worked. No one has the so I go one step higher and we'll talk about gonadotropins. Gonadotropins form the second line of ovulatory induction agents in class 2 who fail to ovulate with Clomiphene and with letrose. They are also the mainstay in ovulatory women as well who need higher forms of ART. And gonadotropins have to be used only after tubal patency has been established. Now, the available preparations that are there today in the market are the traditional HMGs, the pure FSH and the recombinant FSH. Whatever be the case, there is inadequate data which tell us one is superior over the other. The pregnancy outcomes that are there with all the 3 are fairly equal. Now, the mainstay is to promote monofollicular growth. But gonadotropins do promote polyfollicular growth as well and are notorious for ovarian hyperstimulation syndrome, both of which we are not very happy unless we look at higher order ARTs. Now, how do we regimes of gonadotropins? If we look at it, we have multiple regimes of gonadotropins. The classical step-up approach, the step-down approach, and the chronic low-dose approach. But the accepted form of regime today is the step-up approach, where you start with low-dose gonadotropins and you gradually increase your dosage depending upon the follicular response and the serum estradiol levels. Everything is ultrasound monitored. Transvaginal ultrasound is the mainstay. Deepthi knows very well. Ultrasound monitoring and serum estradiol levels are a must while one is on the gonadotropin regime. They don't come without their side effects. They are very, very notorious. We have to keep a watch on the side effects of the gonadotropins as well. The mild side effects that we normally encounter are nausea, vomiting, repeated injections, injection abscesses, feeling of bloatedness and all, which wean off. The more deadly complications that we have to keep in mind are the ovarian hyperstimulation syndrome and the multiple pregnancy rates. There are studies which show that there have been a slight increase in the ectopic pregnancy rates as well with gonadotropin usage. So we should use it with caution, but they have their own beautiful effects as well.
Okay, so I actually understand. So we have plenty of options available. It's not like we are in dearth of drugs. So we have Clomiphene, we have letrose, and we have gonadotropins combination with either a Clomiphene or a letrose. So all what we are interested in is a live pregnancy rate. So that's what we are all coming toward. So Nithya, why don't you elaborate on fecundity rate or a live pregnancy rate with your drug?
Sure, Deepthi. The ovulation rate with Clomiphene citrate is about 60 to 80%. And the cumulative conception rate is about 60 to 70%. But the cycle fecundity rate is only around 15%. And I think it is similar to letrose also. See, there was an old school of thought that Clomiphene brings about miscarriages. That may be because of its long action. It's not like letrose. It binds for weeks rather than for hours in the body. And so that old school of thought is now not there. It does not affect miscarriages.
Okay.
So I think still, after all the debate, my point would be I will still stick on to Clomiphene.
Okay, so she is very strong now. I'll go to Anusha. So are you still sticking on to Letros, Anusha, as the first line?
I'm sticking on to Letros
Okay.
because Nitya spoke about a cycle fecundity rate where I score more.
Okay.
Okay.
We score up to 48%
Okay.
when we use Letros. Also, another important point is about ART, BMI, and pregnancy.
Yeah.
Okay, Letros scores there.
Okay.
Okay.
The live pregnancy rate and the cycle fecundity rate and cumulative ovulation rate is also high in an obese patient who uses Letros.
Okay. So Kritika is going to be neither this way nor that way.
I can join in with either of them.
Neither of them.
I can join in with Dr. Nitya with Clomiphene. I can join in with Letros as well. As long as you use gonadotropins, it definitely improves pregnancy outcomes. It improves fertility, and positive pregnancy rates with the live birth rates are far higher when used judiciously in combination with Clom or Letros. Either of it, these two can choose.
Yeah, so and make sure that the patient ends up with a follicular scan, because there's some plenty of patients who just take the drug and they don't end up for the follicular study. They ultimately come with a distended abdomen with an OHSS. So that point needn't be stressed upon. Apart from that, we also have to involve lifestyle, no? So we've just gone into medical.
Yeah.
So how important is lifestyle changes in these patients?
Very important. I think all our aim is to achieve a normal BMI wherein the dosage of the drugs, the treatment modalities, everything will actually give us a positive outcome. Moderate lifestyle, healthy dietary habits, and more of physical activity definitely needs to be considered in any ovulation induction method.
Okay.
Whatever be the choice.
Okay, so actually the difficult job is for me to conclude this debate. So when I started, I thought there are plenty of options, so we can actually get into one protocol as such. But honestly speaking, every drug which we have chosen has its own advantages, that like pros and cons, cost effectiveness, its advantages and disadvantages. So there is no one drug superior over the other. I'm pretty sure my panelists will agree on it. So there is no set pattern. But the first thing would be patient selection. The patient selection criteria is the first most important thing before starting any drug on any medications. Criteria along with the investigations as a whole before starting them. They'll be very they'll be trying us to push to start the treatment, but unless and until all the baseline investigations are done and parameters are done, we don't start. And the first drug, depending on all the other management protocol, we can start on whichever drug you are comfortable and you have been using for quite some time. Polycystic ovarian syndrome, as we all know, is the most commonest syndrome which we are going to come, and without weight reduction, lifestyle modification, none of these are going to work. So rather stress a lot on preconceptional counseling, weight reduction, lifestyle modification, quantified nutrition. I think we can't be more stressful than this. So the first line of ovulation drug would definitely be a Clomiphene, and resistant would include metformin and gonadotropins. I'm not letting you down, Anusha. Recommended second line is definitely going to be Letros, and it has to be a patient-tailored approach. So I think whatever the points which we wanted to convey, we have brought out. And would you like to know more information? Please log on to www.chennaiwomensclinic.com. You can also subscribe to us on Facebook or Instagram or YouTube. If you want to text us or WhatsApp us at 733 877 1733. Thank you.